Hello, good morning, everyone. Welcome to this new episode of Pablo Aglioni's podcast. Today is September 30th, and we are joined by our colleagues from the Argerich Hospital in Buenos Aires, where they will be presenting a talk about severe tricuspid insufficiency and its treatment, and then we will listen to two clinical cases. I'll leave you with them and enjoy the conversation. Hello, my name is Federico Guequesher. Along with doctors Federico Blanco, Carolina Galvez, and Gerardo Digena, I am part of the hemodynamics service at the Argerich Hospital in Buenos Aires, Argentina. Today we will present a review of bibliographic articles about the percutaneous implant system for the resolution of severe tricuspid regurgitation, and then we will present the initial experience of our hospital with two clinical cases. I hope you can take advantage of it and find it very useful. Transcatheter implantation of the B-cava system for severe tricuspid regurgitation. Today we are going to analyze two articles, one of which was published in journals in September 2023 and the other in May, which compile current data and current techniques for the treatment of severe tricuspid regurgitation from an endovascular perspective. When we analyze severe tricuspid insufficiency, we are faced with a major dilemma: tricuspid valve repair or tricuspid valve replacement. Regarding endovascular treatment, there are two large groups of therapeutic options. On the one hand, we find devices aimed at repair, that is, both the valve and the ring, which in this way attempt to mitigate the effect of severe tricuspid insufficiency. And on the other hand, there are innovative devices that are divided into orthotopic or heterotopic according to whether they are implanted in the plane of the tricuspid valve annulus or not, respectively. Of which the heterotopic that we have used in the cases that we are going to present below with Dr. Galvez in figure Q, you can see the device that we have used, which is a percutaneous B-cava implant system. In figure Q in the panel on the left, you can see the prosthesis corresponding to the superior vena cava, while in figure Q on the right, you can see the prosthesis that goes in the inferior vena cava. Below is a list of devices approved on the market for use in humans for the endovascular treatment of this pathology. The main benefits of tricuspid valve replacement are, firstly, the practically complete or complete elimination of severe tricuspid insufficiency, and secondly, that they require less dependence on anatomy. That is, since they are independent valve devices, this means that they do not depend as much on anatomy as, for example, repair devices do. The downside is that it is a more invasive procedure and usually requires anticoagulation, as we will discuss in the following slides, and this means that patients who are not candidates for open surgery are more likely to be selected for repair treatment than valve replacement. The European and American guidelines in their older versions have presented the indication for treatment of this valvular disease only from a surgical or cardiovascular surgeon point of view. However, today, due to the concepts of fragility that we have learned from other valves such as the aortic valve in TAVI, it has been shown that these patients live longer and their quality of life is affected by the lack of treatment of ovulopathy. That is to say, through this therapeutic alternative, heterotopic alveolar replacement, the patient can improve his or her functional class, measured both objectively through different tests, such as the 6-minute walk test, or subjectively, for example, through questioning or through different quality of life scales. Not only this, but it improves echocardiographic parameters such as tricuspid regurgitation, hospitalizations, proBNP levels, and diuretic dose over time. As far as anticoagulation is concerned, this is a controversial point of view.
Some studies recommend oral anticoagulation for a period of 3 months. However, our group and many other authors consider that the high prevalence of concomitant indications, such as atrial fibrillation, makes it impossible to think in terms of a 3-month period, and we consider that it should be extended for life. From a hemodynamic point of view, the venous system also constitutes a low-velocity system compared to the arterial system, and therefore it is important to emphasize that it is more prone to thrombus formation. It is important to have carried out an adequate workup of the patient, that is to say, not only to perform the ultrasounds, the laboratory, but it is also important to have previously performed a right basal Swan-Ganz catheterization in order to have a reference for the curves. The curves after tricuspid valve implantation generate changes. For example, in the figure above, we see the pressure curve for the inferior vena cava. It presents a behavior similar to what would be the pulmonary artery with a dysphasic component, while in the case of the right atrium, we will see a ventricularization of the pressure wave. In conclusion, the implantation of a bicabal tricuspid system for severe or massive tricuspid regurgitation constitutes an effective treatment for the pathology in question. There are multiple endovascular therapeutic options, which are divided into tricuspid replacement and repair devices. The bicabal tricuspid system implant allows us to reduce the diuretic dose, improve the functional class, and therefore the quality of life in these patients. Anticoagulation is initially recommended for life. Treatment of tricuspid regurgitation also results in laboratory improvement with significant reduction in BNP levels. And there is a change in the hemodynamic parameters, which could generate reverse remodeling effects, as we will discuss below.
Thank you so much.